Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Welcome back, everyone. I am so excited today because this is our very first podcast episode where we are being joined by one of our local urogyns who's not only an amazing physician, but also just a fabulous person and one of my really wonderful friends, Dr. Sarah St. Louis. How are you?
Good. Thank you so much for having me. I'm excited.
Me too. I'm so glad that you are my first interviewee on the podcast because I couldn't think of anybody better to do it with.
Awesome.
So tell us a little bit about your background and training and kind of what brought you to urogynecology.
Yeah, so I started out doing OBGYN. And actually a year before that, I had done a general surgery intern year. And when I was doing my urology rotations, I thought it was just really neat. The whole process of reconstructive surgery and tying it into women's health. So I then did my OBGYN residency and then applied for my gynecology fellowship and did that in New Jersey. And then I've been in private practice since that point in time. And then also just as I've grown my practice and over the last several years, I've started to get really interested in sexual wellness, intimate wellness, for women, as well as alternative therapies for treating basics like pelvic floor dysfunction, incontinence, and prolapse.
I think that's such a natural transition. You know, when you are a vaginal health expert and you're helping women with all of their pelvic floor issues, it just naturally flows into sexual health. And that's a part of my practice that I love that part so much.
Yes. You've been instrumental and definitely someone I look up to in how you have developed your practice and care for patients over the years.
Oh, thank you. Well, we've talked about it before that it's really just been a natural progression. I think if you take good care of patients, they trust you and then they want you to take more care of them. So then you push yourself to learn more about, as you were mentioning, maybe not some of the standard medical treatments, but some of the alternative treatments. What else can we do to improve women's sexual health with hormones and with injections and with other vaginal services that keep the vagina sensitized and feeling great?
Right. Absolutely. I think it's so important to think outside the box and collaborate with other scientists, research, and other female physicians that are looking for these optional treatment methods. So
Exactly. No, I agree. Today, we're going to focus on what we as urogyns wish women in general knew, because I spend so much of every one of my new patient visits educating women about anatomy and bladder health and sexual health. And what I've really come to learn over so many years is adult women don't have this information. We do not get taught good information about our own body, our own sexuality, and most physicians are not providing the education. Do you agree with that?
I 100% agree. And I think that once the education and the knowledge is there, then both the patient and the physician can come to a conclusion and a course of treatment that works. And yes, I every day I'm amazed. It's actually what started my intrigue into women's health was I went to an all women's college. And I remember thinking there's a group of educated women, and yet none of us know anything really about our anatomy, contraception, just basic gynecologic care that any young woman needs to know.
I totally agree. And all of my friends are professional and well educated, highly educated. But as we all entered our mid 40s and beyond, the perimenopausal change, no one had any clue. And
No.
as I started to even educate just my girlfriends, they were shocked. I had no idea that was part of it. I had no idea. And these are,
Yes.
these are highly intelligent ladies.
Yep. Yep. And you're also now at the peak of your life as far as your family lifestyle, work, career and academic achievements and what you're doing in your professional and personal lives. And then here we are being hit with the whole perimenopause situation. And what you were saying about what do women know and what don't they know and why, I think it's even interesting as gynecologists being trained in gynecology, in all honesty, even our training is lacking. So it's hard for us to educate our patients if it wasn't even a big highlight. We were so heavily focused on having babies, birthing babies, being an obstetrician. So I think that's a big part of it.
Oh, absolutely. Absolutely. In medical school, there's minimal, if any, discussion of perimenopausal change of the perimenopausal change in menopause medicine. And even you think in OBGYN specialty training, well, you'll get it there. No, very little
No.
training, if any. So I'm always loving to reach out to other passionate physicians who have gone beyond their traditional medical training and looked at all the wealth of knowledge that is there. It's just not available. It's not being given out by primary care. It's not being given out by endocrinology. You really have to find your passionate menopause provider.
Yes. And on top of that, as providers, we have to deal with almost being shunned that we want to seek out that information. It wasn't in our medical textbooks. I mean, when I just listened to what you said, we took classes in endocrinology, we took pathophysiology. Um, I don't recall a chapter talking about vulvovaginal symptoms of menopause at all. I don't recall any of that.
Exactly. I remember in my residency, we had a private group that was some of our mentors. They were two female providers, female OBGYNs, who
Mhm.
they themselves were very loud proponents of hormone replacement therapy at the time of menopause. And they, in the group of educators within my residency, they were kind of looked at as, oh, those are the two crazy ladies, over there talking menopause medicine. But what they said at that time really resonated with me. And one of their statements was, if any other endocrine organ in our body dies, if we remove our thyroid, we get thyroid replacement for the rest of our life. If we remove our pancreas or our pancreas doesn't work, we get insulin therapy for the rest of our life. But when the
Yes.
ovaries die, we kind of put up our hands and go, oh, well, just deal with it.
Hmm.
And I thought
Hmm.
that makes total sense. This is a vital endocrine organ that women didn't used to outlive. We used to die before our ovaries kicked out. And
Yes. Yeah.
now we live obviously 50 plus years beyond where our ovaries have kicked out. And we just let women suffer because of it.
It's yeah. I've even spoken to patients that are having surgical menopause, removal of their ovaries for another reason, and they mentioned that they were not aware that they should be considering hormone replacement therapy after this.
Yes.
So,
Zero conversation in the pre-op
yeah.
consultation, where when we talk to patients about the risks of the surgery and what they can expect, but
Mhm.
no information about what hormonal changes to expect, not only in the short term, symptoms of hot flashes, night sweats,
Yeah.
brain fog, but the long-term health risks, their
Mhm.
increased cardiovascular risks,
Yep.
their increased
Oh.
dementia risks, all those
Hmm.
things, nothing
Yep.
gets discussed.
Nothing. Yeah. It's really actually fascinating. I thought about it when I finally finished practice, and was presented with my first patient that was asking about hormone replacement therapy. I looked back and I said, all of the residents, we have residency clinics, there was not a single prescription I ever wrote in 4 years of training for hormone replacement therapy in my residency.
It's crazy. Yeah. There's just no good education on it. So, oh, that's so exciting. We're definitely having you back for a whole discussion on menopause
Yes,
health
why
for
not?
sure.
I would
All right.
love to.
Good. Well, today we'll get back to things that we wish women knew about themselves from a Urogyne perspective. And my first thing that I always want to know is what don't women know about their own anatomy? And what should we be teaching women about their vaginal and vulvar anatomy?
I think that one of the big ones that we see is, where's the urethra and what is the urethra? What is the purpose of it? What kind of a lot of things that women don't know also is the pelvic floor muscles, right? How to use them, when to use them, why we need them, what the purpose and function of them is. I think those are big ones that I wish women knew more of, as well as just the simple explanation of what is the vagina, right? Where does it start?
Hmm.
And it's the difference from the vulva. Those I think are my kind of top three.
Oh, absolutely. I think that I know in middle school, probably we start to teach our kids about sex ed, and it's very focused on puberty and puberty changes, which of course makes sense because that's what those kids are about to be facing. But I so firmly believe we need to be teaching both boys and girls the proper terms for all the female anatomy. The male anatomy is easy. It's all on the outside. Everybody knows. It's easy to point
Yep,
to. But
right
I
there.
think if both men and women understood at a young age, this is what the female anatomy is, this is what's normal, it demystifies it and it makes it easier to talk about in all circles.
Absolutely. That's an interesting one because then that makes me think about intimate wellness in the future. Um, uh, for reproductive health purposes as well as just your own intimate wellness with your partner. It's interesting because if men and women don't know, then you potentially have situations where partners are together and they are not functioning the way that they should or could, or there can be pain issues that we know about. And I think that if everyone just had a little bit more information and it was demystified, then more and more people would know.
Oh, I
And
exactly.
yeah.
I mean, I think about how that does lead into healthy sexual
Hmm.
relationships.
Hmm.
If women understood all of the positive sensitivity they get from vulvar stimulation well before even thinking about penetration, number one, they'd be more empowered to ask for it. But if
Yep.
men understood that basically, they wouldn't even go near a woman thinking about penetration until
Yep.
they've given her
Yeah.
tons of pleasure, stimulating the
Yes.
labia, stimulating the
Yes.
clitoris, all those good things. And,
Yes.
all the,
I think
manly
that
men
that
who feel
yeah.
like they're fabulous in the bedroom. You're like,
Yes.
are you really? Or,
And and I think what's really interesting, especially as women get to this decade of their life, they recognize that the most positive or affirming sexual relationships they've had probably are with a partner or a man that was not focused on penetration, and that
right.
is something that even women at that point in their lives didn't even realize that that's what was needed or they like or can ask for. I think that's really eye opening, is like you said, vulvar stimulation.
Exactly. I counsel a lot of couples. I'm over age 50, and
Hmm.
I am always talking to them. It's not, they may have had penetrative sex their whole life, and it's not that it feels bad. These aren't necessarily women having pain or difficulty. They enjoy penetrative sex, but I'll
Hmm.
say, do you know how much you're missing by only focusing on that? And you may not realize how exciting it is for your male partner to give you fabulous pleasure without penetration. So, a
Absolutely.
lot of those women are a little fearful to ask for it. Maybe they know that it feels good to have external stimulation, but they're fearful to ask for it. And I constantly tell them, when your partner sees you completely enjoying
Yes.
yourself, that's a huge turn on to them. So
Yes.
allow them to give you that pleasure and experience that for themselves.
It's interesting to piggyback off of what you said is the fear of thinking it's almost like women are programmed at a young age that penetrative sex is the only thing you should be interested or asking for. If you're asking for something different, you're the quote unquote weird woman,
Right.
and what's wrong with you? It's almost like you're not supposed to think outside of that box.
Oh, absolutely. I mean, sure, sex has the purpose of procreation, but
Mhm.
99% of the time couples are having sex. It is not with the end goal of procreating, it's with the end goal of pleasure.
Correct.
So there are
Correct.
so many other ways to have pleasure outside of penetration.
Yeah, yeah. Very, very, that always gets me going, this whole conversation and topic.
Yeah, absolutely. And I love just seeing it, the light bulb go off in women's head when they're like, "Oh, I can ask for that. It's normal. I'm supposed
Mhm.
to feel good doing that."
Yep. Yep.
And of course, even if their male partner is with them at the same time, that's even better because they're sort of
Yep.
hearing it from a professional rather than just hearing it from their wife or their female partner, and they're thinking, "Okay, this is really valid."
That's true. Yeah. It's a good third party
Yeah,
to
exactly.
the conversation. Yes.
Well, let's pivot into one of the conditions that we see constantly, which is pelvic organ prolapse. Tell us a little bit about how women get prolapse, what it is, and how we get it.
Yeah, so I always like to describe prolapse as a hernia of sorts, just a hernia that is taking place in the pelvic floor. And anytime you have a soft body cavity that doesn't have any structural support around it, if there's a weakening of the supportive tissue there, whatever organ is behind that supportive tissue can basically bulge, or drop or poke out or whatnot. And one of the things that, again, we're always so focused on in our lives and in our careers on having babies, vaginal delivery, C-section, how many children. And one of the top reasons that women experience prolapse is just a result of the gestational process, as well as the delivery process of having children and the number of children that we have. So, those types of things, as well as genetics, connective tissue disorders, or repetitive heavy stress on those muscles, is what actually puts women at risk for developing prolapse.
Exactly. And I think a lot of women feel like they develop a prolapse because their muscles are too weak, the muscles in their pelvic floor. And I'm always telling them that it's not your pelvic floor muscles that are the support of your organs. It's the
Mhm,
fascia, for lack of a
mhm,
better term, which is this much stronger supportive tissue. And once
mhm.
that fascia is weakened or torn, I don't care
Yeah.
how strong your muscles are, something is going to bulge down. Now,
Yep.
strengthening your muscles is still a good option. Keeping your pelvic floor healthy might reduce some of those prolapse symptoms, but it's not going to cure them. It's not going to pull an organ back up just by doing some pelvic floor muscle exercises.
Absolutely. Yeah. It's almost like, it's like putting a brace around an injury. It's
Mhm.
gonna add support, but it's not going to actually fix the injury. I
Yeah,
agree.
that's a great analogy. And a lot of women also don't realize that the injury to their fascia, yes, occurs with carrying babies and vaginal delivery, but they don't see the prolapse right away because we tend to have babies when we're young and all that surrounding muscle and supportive tissue is healthy. Our hormone levels are great when we're young, so tissue stays strong. But as we age and as we go through the menopausal transition with the loss of those hormones, now suddenly we start to actually feel the results of having that baby 20 some years ago.
Yes, yes. I think that's also a concept that I wish were easier and more discussed. Is, well, why didn't I see it 20 or 25 years ago? And I always talk about, the importance of estrogen. And when we start to lose estrogen, we lose the collagen, we lose the elastin, and we see the effects of that all over the entire body, skin, everywhere. And so, of course, it's also going to affect um, uh, the pelvic floor. And I think that we're just not told that. Like, no one's thinking, oh, the effects of age and gravity are going to affect me down there. We're just thinking about it in these other aspects, hair loss, skin, moisture, dryness, irritation. But all of the same things happen within the vagina. And I think that's something that a lot of women don't realize, that they'll start to notice that.
Exactly. One thing that always frustrates me, just because it's my colleagues in
Mhm,
gynecology, someone gets
mhm.
sent to me and they'll say, I was in the shower the other day and I went to wash myself, and oh my gosh, I felt tissue that wasn't there. It happened on Wednesday.
Yes.
And I'll say so of course I'll do their exam and I'll find their prolapse and I'll say, this didn't happen last week. This has
Mhm.
been slowly developing over time, probably over a period of several years. And if I see someone with a fairly advanced prolapse, I know that their gynecologist has been watching that come down slowly for many years. And of course, the patient has not been notified of it. She's completely unaware
Yeah.
until it's now outside of the labia and it's very obvious to her.
Yes, yes. Another interesting presentation, and I'm sure you've seen this, is the patient is frightened. They feel in that area taking a shower, cleaning, and something just feels different. There's tissue that's different. Then they come in and they're sent to us, and there's not a prolapse. It really is just the simple fact that the vulvovaginal anatomy changes. And again, it didn't happen overnight, but there have been changes in the lining of the vagina, the tissue around the urethra. And yes, it looks different and feels different, but it may not be a prolapse.
Exactly. And this is the vagina and vulva are not an area that women are getting out their mirror and examining carefully every
every
day. I mean, I'm in my
Mhm.
makeup mirror, my 10-time makeup mirror, examining every pore in my face every single morning, but we don't do the same thing with our vulvovaginal tissue. So it just sort of hits us one day, like you said, when we're like, hey, that feels different, but you don't realize it probably has been slowly changing over time. It's just not as
Yep.
noticeable.
Yep. Absolutely. Absolutely.
So if we do find that a woman has a prolapse, um, the first thing she's always going to ask is, I'm so fearful. I haven't done anything. I haven't had sex with my husband. I haven't exercised. I haven't lifted up my grandkids because maybe someone told them, don't do anything. It's going to fall completely out.
Yeah. Yeah.
So, what
Yeah.
types of lifestyle activities do you recommend that patients either do or avoid once they have a prolapse?
I recommend that they enjoy any of the things they were previously doing. A big one, I'm like, please be intimate with your partner, have sex, do not avoid it. You're not going to hurt anything, and it's not going to fall out and off of your body. And I also, a lot of patients are scared to exercise or do their water aerobics or go swimming, and I always encourage them to do those things. Um, I really only talk to patients about avoiding things that could potentially cause more prolapse, like constipation. I'm going to say do your best to avoid constipation. But other than that, I encourage, most all activities. What about you?
I agree 100%. The first thing I try to do when I diagnose a new patient with prolapse is provide reassurance. This is soft tissue. Absolutely, you can have sex. It's just going to push back in and come back out, and you're not hurting anything. You might even be strengthening your pelvic floor muscles a little bit by having regular intercourse. So that can actually improve it. But I tell them any activity that feels comfortable for you to do it. Now, we do know certain activities, if they are straining type activities, like squats and lunges, especially if they're doing them with weights in their hands, they're going to be more aware of their prolapse at those times. And absolutely, we have things that we can help with that. But once they have prolapse, as I mentioned, the tear in the fascia has already occurred. It's there. And
Yeah,
unless we do something about it, it's going to be there. So you're really not making it worse by doing your normal life activities.
I agree. I agree. The reassurance is key for patients.
Exactly. So then the next thing patients get told is, well, you have some prolapse here, just do some Kegels and that'll help it. What do you think of that advice?
So I always like to say consult with a physical therapist prior to starting any kind of Kegel exercise. And most women have been doing Kegels or trying to do Kegels for the majority of their lives because we've been reading it in Cosmopolitan magazine since we were 15. We've heard about this magical exercise. And I always like to talk with the patients and tell them, look, especially if you've done Kegels and the doctor has assessed that you're doing it the right way, it may not fix anything. It may not make anything any better. And of course, as we know, sometimes it can actually lead to more trouble, more dysfunction of the pelvic floor. So I always like to say, let's start out with like a healthy assessment, an exam, see how strong the muscles are. Can you recruit them? And then you might need to see a physical therapist to develop an exercise program. And sometimes these can definitely help prevent worsening of symptoms. But like we said, it's not going to correct a prolapse or correct a tear, but it can certainly help with symptoms.
Exactly. I think I love our pelvic floor therapists. I use them constantly in referral in my practice. But I think that working with a pelvic floor therapist and strengthening your pelvic floor muscle has better symptomatic relief of things like urgency and frequency and maybe a little bit of urine leakage. And it really only helps prolapse if you're in the most mild category, where it's just maybe not so much a bulge, but some vaginal heaviness or pelvic heaviness that you feel. Maybe you can relieve that a little bit. But you're not hurting anything necessarily by doing your Kegels, but you're probably not going to make a huge difference. And I try to take away that guilt. I think a lot of women feel like, oh, I did this to myself because I really
Yeah.
haven't been doing my Kegels in the last 10 years. I'm like, well, are
Mm.
you bending, lifting, urinating, moving your bowels? Though all of those things activate your pelvic muscles. Like
Yeah.
they're not paralyzed.
Yep, yep, that is true. And I also like to go over just in general, because as women, we don't talk about prolapse a lot amongst our friends or we're leaking. I like to go over the numbers and say, look, it's sort of a very large group. This is more than likely going to happen to most women. So I like to also reassure them they didn't do anything wrong. And while it is something that occurs in many women, it's not something that they have to necessarily just live with or be bothered with. So And then also what you were saying, I really love the physical therapy aspect for those overactive bladder symptoms and the leaking. I think that's something that is not discussed enough is what they're able to accomplish with waking up multiple times at night, getting to the bathroom calmly without feeling like you have to run. Those types of things are really, uh, they can really be worked on with physical therapy.
Exactly. And I often tell patients, you may have more than one thing happening at the same time. You've got some prolapse, so you feel a bulge at the vagina. But you also have the feeling of always needing to urinate and rushing to the bathroom or not making it there in time. Those can exist together, but are managed in different ways. And fixing the prolapse doesn't automatically
Yeah,
fix your urinary
yeah,
incontinence and rushing to the bathroom. So we may have to deal with that separately. And
yeah.
that's, I think, really important for people's expectations about our
Yes.
therapies.
That is a big one. I think we spend as urogynecologists a lot of times doing that type of education that, I'll say you have more than one diagnosis. And it's really important to establish that if your bladder is dropped, which is very common occurrence, um, it doesn't mean that by fixing that you're going to now not use the bathroom as much or not have to run to the bathroom as much. And I think that is, like you said, I echo that sentiment. Those are things that we typically manage differently.
Exactly. And speaking of how we go to the bathroom, another thing that I spend a lot of time educating women on is what is normal voiding and what are normal bladder habits. Because, boy, women get told a lot of crazy things about how we should pee as we're growing up as girls. I've heard so much insane stuff. So let's talk a little bit about what are normal voiding habits. How should we help, do a healthy urination? How are we seated on the toilet? How often should we go? Things like that.
That's a good one. That's a great question. And we could probably talk about that for a long
Right.
time. But in general, what we use medically is that someone should be using the bathroom on average 7 times per day or less. But then again, it depends on water intake, medications, age. There's so many things that play a role in that. And in general, we want patients to not be waking up more than 1 to 2 times at night, and that number can change as we age as well. As far as voiding patterns, we're told as little girls to squat and hover. And then a lot of times that can end up causing some voiding dysfunction, that we need to kind of retrain and reprogram women that it is okay to sit on the bathroom and relax yourself. We shouldn't be using like extra straining or pushing to empty our bladders. So those are some things that I think about when you phrase that question.
Oh, definitely. Our favorite saying in our office is cover, don't hover. People don't like to sit on the public dirty toilet seat. They're worried about infection. I say, fine, put down as much paper or toilet seat covers as you need, but sit all the way down, feet on the floor. Your pelvic floor muscles first need to relax to
Yep,
allow the bladder muscle to open. And then, of course, secondarily, then the urine can pass. So we know that it's a pretty complex series
it
of
is.
muscle and nerve firings that have to occur in the right sequence in order to urinate properly. But if you spend a lifetime either lifting your butt over the toilet seat, or if you spend a lifetime as a teacher or a nurse and suppressing the
Exactly.
need to go to the bathroom for your 8 hour, 10 hour, 12 hour shift, you're going to mess up all of those normal signals that have to occur. And over many years, you can get yourself into some pretty good voiding dysfunction.
Absolutely. Yeah. I even recently had a career patient that is in the police force, and they have to do, I guess, they're investigative and sit in a car for 8 hours at a time, and it can lead to some bladder dysfunction, in the future. So yes, I agree. There has to be this process of allowing the pelvic floor to relax so that your bladder can then start the process of emptying.
Exactly. It's funny you mentioned the police. I also had a woman working in the sheriff's office who told me the exact same thing. And
Yeah, yeah.
she found a device online. It's called the PZ,
Oh,
PEEZE.
oh, I've got. Is it one of those voiding devices that you can
Well, it looks
utilize?
sort of like a plastic funnel, but it's kind of shaped like the female vulva. So it fits over
Yes.
the vulva and allows, because she said, my male counterparts, if we are out all
Yes.
day doing like a stakeout or we're in the woods looking for something, the guys will just go behind a tree and urinate
Yep.
when they need to. She said, well, what am I supposed to do? Right? I can't just go out and
Yep.
squat somewhere. So she now carries this with her. So she can also,
It's
like her male
amazing.
colleagues, use the bathroom in the woods if she needs to. And I just thought, oh, good for her for not,
Amazing.
yeah, just holding it all day.
Speaking of that, there are some devices, I suppose, that are online or over the counter that women can utilize to prevent leaking or bladder issues. What are your thoughts on some of those, like the vaginal inserts or pads?
So, I mean, I don't, there's the one I'm thinking of that's more of an insert that helps with stress incontinence. So that's
Hmm.
leaking when we cough or sneeze or exercise. I think
Hmm.
that can be helpful, especially if your stress incontinence only occurs during a specific activity. Like I have a lot of tennis and golf playing women, and some of them
Yes.
will say, I only leak when I'm on the tennis court, with all that stop and start motion of playing
Yep.
tennis. Other
Yep.
times I'm really fine. So I think in those isolated situations, a little vaginal insert might be helpful. It's putting a little extra pressure on the urethra, helping to keep it closed. But then many other patients are having leaking every time they cough or sneeze, which of course is unpredictable. And so for them, they'd really have to wear it all day long because you never know when that's
Right.
going to occur. That might be a little more challenging. You can only wear it for up to 8 hours at a time. So you'd have to change
Yep.
it and it becomes a cost issue.
Absolutely. Absolutely.
Yeah.
Yes, there's quite a few things that are on the market that are very interesting. And then of course in our office, I'm not sure how your practice is, but we can also fit with the pessary, which is a little bit more cost effective as well as can be worn for longer periods of time.
Exactly. And I think, again, that can be helpful because you can wear it all the time to help prevent leakage if you have unpredictable leaks. Or if you have an activity, you can just pop your pessary in right before your tennis match and take it out if you don't need it afterwards. But it certainly is, we know a lot about pessaries. We have a lot of shapes and sizes to fit a whole bunch of different women. So that can often be a much more comfortable way to go.
Yes, that's another something that I often find myself counseling patients is the fitting with a pessary, right? And I think sometimes patients have either had a friend or a family member that's had one, it's not fit, it's fallen out, or it's uncomfortable. And I always like to let patients know that there's a pretty good success rate of finding one, but sometimes it is a trial and error process. Not every pessary is made for every woman. We have to do different shapes and different sizes.
Right? I think pessaries in general get a bad rap. I feel like everybody knows one person who had a horrible pessary in, lots of yucky discharge, and oh, they just think it's for old women
Yeah,
who, get forgotten. And I say that is just in my practice, absolutely untrue. We have a huge practice of
yeah,
very happy pessary wearing patients who
yeah.
either manage the pessary themselves. If they're comfortable taking it in and out themselves, they certainly can do that. But I would say the majority of them allow us to care for it. So they just wear their pessary for several months at a time and pop in and they
Yes.
have their little social visit with me when I do their pessary
Yeah.
care,
Yeah.
catch
Yeah.
up on their grandkids.
And I even have, like you said, some young, active marathon running ladies, and they're not ready for a procedure or a surgery, or they think they may have another child, but they wear their pessary when they're doing their, high impact or long term exercise programs and training. So I think that they can be a perfect fit for many different women.
Oh yeah. And we've specifically been talking about pessaries for incontinence, but obviously we also use pessaries for pelvic organ prolapse. I also think they're a great option for young women. We do occasionally have some young women who after baby number 1 have fairly symptomatic prolapse.
Yeah.
And they're not ready for a surgical procedure because they're not completed their family. And I don't want to do a giant vaginal repair and then have the next baby tear it all up. So a
Yeah.
pessary is a great option for them to use in between babies and then when they're finished completing their childbearing, if they would like a vaginal repair, that's a great time.
Absolutely. Yes. And I would also say we see that a lot in surgical planning, right? Because I'm always talking with patients, and when they do notice they have a prolapse and it's bothersome, it's not an emergency. And if we need to plan around lifestyle, maybe you're a teacher or something like that, and we can't do a procedure until next summer or over the holidays, a lot of patients will utilize that pessary almost like a brace, just to kind of bridge them over until a better time in their life to fit in a surgical procedure.
Exactly. And some of them find out oh, this is actually working great. Maybe I don't
Yeah.
need a surgery at all. Maybe I'll
Yeah.
just manage my prolapse long term with my
Yep.
pessary, and that's perfectly acceptable. So,
Perfectly fine. Yeah.
yeah.
I have a
So,
lot of patients ask me, how long can I use a pessary for? I'm like, as literally as long as you want, the rest of your life.
your whole life. Exactly. Right. As long as you want to not feel your vaginal bulge anymore.
Yep. Yep.
Right. We love them. I think they're a fabulous tool. It's not mandatory to try a pessary leading up to surgery, but it's a great option for patients. And I always look at it as a trial pessary fitting. I say, look, it's a very high likelihood we will fit you with a comfortable pessary, but it may take us a few tries. We may have to try a couple different sizes. And every now and then it doesn't work. And then we know we've tried it and we can always move on to surgery sooner if necessary.
Yep. Yeah, that's true.
Right.
I always like to discuss with the patients the conservative options first because we can always try those and we can decide they're for us or not for us. Once we try surgery, we can't take that back. Although, of course, we get great long-term results, lasting results with surgical procedures as well. It just may not be right for everyone right away.
Exactly. And we were started off talking about good bladder habits, and you mentioned something about there's such a variability, and a lot of that is how much we drink. And we're such a water-focused society.
Yeah.
Everybody's trying to lose weight, everybody's trying to be healthy, and drinking gallons of water every day.
Yeah.
And our bladder it's just a vessel. It is a fluid storing device. It can only
Yep.
store so much
So
fluid. When it
much.
gets full, it's got to empty. So obviously the number of times you need to go, of course, is going to be related to how much you drink. But I tell patients if you're drinking a lot, you're urinating a lot. But it
Right.
still should be you can walk comfortably to the bathroom and get there without leaking. So you might be urinating 10 times a day, but
Yeah.
you make it there every time and you're not rushing. That may be normal for you versus someone who's only urinating 4 or 5 times a day, but every time they're leaking before they get there,
Yeah.
that would be an abnormal pattern.
Exactly. Exactly. Yeah. There's definitely a big difference between those two.
Yeah. And I think many women can very safely reduce their water intake.
That's
We
true.
we don't
That
need
is
to be
true.
drinking gallons and gallons per day, especially if it's bothering our bladder and making us go more
Abs-
often. Yeah.
Absolutely. Every so often, there's definitely a patient that we see that we realize this is simply an intake situation, and we don't need to do medical management, medications, or procedures to treat the overactive bladder symptoms that they're having. So that's a really important one.
Right. And nighttime urination, getting up at night is really bothersome for
Mhm.
patients. I mean, besides the fact that you have to go, it's so disruptive to sleep. And obviously, sleep is so good quality sleep is so critical throughout our life. How do you tell patients to restrict their fluid if they're getting up too much at night to go to the bathroom?
So I try to have them, number one, try to avoid drinking fluid 2 to 3 hours before bedtime. That can be really important, as well as avoiding any bladder irritants in the evening. For me, I love having a cup of tea before bed. It's really relaxing, but I know if I do, I'm going to wake up a couple times that night to empty my bladder. So, a lot of times, I love making some small behavioral changes like that with fluid intake or the choice of foods and beverages later in the day, and seeing like good results. Someone's now getting a better night's rest. And I always like to discuss that although these might seem like things that are maybe silly to even bring up, you might have a patient that's 75 or 80 and says, well, I wake up 4 times a night. That's normal. I mean, look, I'm 80. And it's so important to kind of let these patients know, like, no, we can get you better sleep, better quality of life. You won't be groggy. And on top of that, I always like to talk to patients about like the number one reason that a patient enters the nursing home is their bladder. It really has to do with incontinence. They can't get to the bathroom on time. They're wetting themselves. They don't have anyone to take care of them. So they end up in a nursing facility. And on top of that, if a patient is 80, 85 years old and is waking up at night trying to run to the bathroom and they trip and fall, that's a huge risk for fractures, especially in a patient with osteoporosis, and then entry into the hospital and hospitalization and then complications. So the bladder is critical to and how patients um, perceive. Is it okay for me to get up 5 times a night? I think one of the things I like to kind of talk about is the fact that this is what we do all day in our careers, and there are a lot of options to help decrease that, which actually keeps that patient safer.
I agree. And, people often, I'm sure you hear it all the time too. People will say, "Oh, I never knew a physician like you existed,
Yeah.
urogynecology," right? Until I've had this severe problem. But I
Mhm.
wish people knew we existed much earlier in the continuum of their urinary issues,
Yeah.
because sometimes a woman will come to see me and she'll say, "It's really not that big of a deal." She's almost embarrassed to be here, right? Like,
Yeah.
"It's really not
Hmm.
that big of a deal. I just leak a little bit. It's just in these times." And I'll say, "This is the absolute right time for you to be here. Let me
Hmm.
help it when it's a small problem."
Yeah.
Versus the patient who comes in and says, "I saturate my diaper 3 times a day. I got to change it. It's heavy with urine." I'm going to have to do everything I can for that woman. And I'm still probably only going to improve the situation, not cure it.
Yes.
So
Yeah.
if I can get to her earlier, I am a much happier person because I'm going to have
Yeah.
much better outcomes.
Yeah. And I have to say, I love what we do. It is very satisfying because everyone acts like this is a topic that we can't talk about, hush hush, but yet it's it's a huge multi-billion-dollar industry, pads and liners for urinary bladder leaks. And one of my favorites, and I know is one of yours, is Botox, which we can talk about. Um, and I love seeing patients that are whatever age, 60s, 50s, 70s, 80s, even 90s. They
Yes.
come into your office, they are wearing 4 or 5 pull-ups a day. They get their Botox, and now they are out and about, going back out, having fun with friends and family, not worried about leaking, not worried about how they smell, and wearing maybe a panty liner. It is one of the most satisfactory treatments just to think about it. I think we make it like it's so normal to be in pull-ups. What if you didn't have to be in pull-ups?
Right. Exactly. And I think people don't realize how easy it is to get bladder Botox, how
Mhm.
safe it is. Some people
Mhm.
still feel like Botox is a poison and we shouldn't be putting it in. Botox is one of the most studied products that we put in the human
Mhm.
body. We use it from
Mhm.
head to toe. We use it, of
True.
course, for wrinkles, but we use it for migraines and eyelid
Mhm.
spasm and muscle spasm in the neck
Yep.
and the traps. And we use it,
Yep.
you and I use it in the bladder. And
Yep.
it has such a huge safety record,
Yeah.
that we need to be moving more patients to the Botox option faster,
Yes.
because the medicines that we use as a first,
Mhm.
which are considered the first line treatments, really
Right.
have quite a large number of side effects. And those side effects are worse in older women, which are
Yep.
the women who tend to suffer with these problems.
Yes. Yes. And a lot of patients think this whole Botox concept that it's kind of off the wall. It's covered by insurance. We have
Exactly.
no issues with Medicare patients. It doesn't matter. So I think that also just goes to show how much research is behind it and safety. And it can be something that's done in 2 minutes in the
Exactly.
office.
Exactly. So
So,
well tolerated. And, we
mhm.
always start by following the national guidelines for treatment, and Botox is a part of the AUA guidelines for treatment of overactive bladder. Unfortunately, it's considered an advanced treatment, meaning patients have to try and fail medications first before the insurance will cover it.
Right.
I know that the AUA is trying to move it earlier in the treatment protocol so that we
Would be
don't have to
so
use
great.
these potentially dangerous medications.
Mhm.
We can move right to a much safer option. So that's
Right.
always a little challenging, right? To get
It
insurances to
is.
pay for something earlier in the treatment process, but it really is the safer option in these women, in my
It
opinion.
is. It is. And at the end of the day, I mean, even when we challenge the insurance companies, we write letters of appeal, we let them know about side effects and contraindications for a patient. And it does work, but it also takes time for us to fight that fight. And a lot of times some of these medications are not well covered and they're not affordable for our patients to be spending, a couple $100s a month on a bladder medication when they have heart medications and diabetes medications and things of that nature that they have to worry about on a cost basis. So I certainly hope that we can further that along and make it a primary or first line treatment.
Exactly. I mean, all of the insurances tend to push women who need medication to, of course, the cheapest version, which is
Hmm.
oxybutynin. And we know that's the absolute worst medicine out there for women. It's significantly drying. I mean, they
Yep.
can't even peel their tongue off the top of their mouth. It worsens
Yep.
constipation, which most of these
Yep.
women may struggle with already. But even most worrisome, there's an
Mhm.
association with dementia after using it
Dementia.
for several years.
Yep.
So I just think oxybutynin should not exist as a
I
medication
know.
option. But
It
it's
is
dirt
very
cheap.
frustrating.
So of course
Yeah,
insurances want you to use it.
absolutely. It is very frustrating to try to fight that fight, and as well as the blurry vision. In particular, we have a lot of patients with the autoimmune diseases and Sjogren's, and people think that dry eyes and dry mouth, oh, that's not too bad of a side effect. I mean, it can be absolutely miserable for patients. So
Exactly.
yeah, I
Yeah. It's
agree.
not just like a little bit of dry mouth. It's
Hmm.
severe. It's pretty bad. I
Yeah.
actually earlier when I was in my 40s tried some of our samples of one of the antimuscarinics because I was having a little bit of overactive bladder.
Yeah.
I couldn't talk to my patients. I mean,
Oh my
I'm
goodness.
working
Wow.
my mouth and talking to patients all day, and
Yeah.
I was having trouble moving my tongue in my mouth. It was so dry. And I
Wow.
just thought, and we know that the discontinuation
Yeah.
rate for these meds is so high for that reason.
Very high.
I
Mhm.
was like, I'll run to the bathroom rather than not be able
Yeah.
to speak properly to my patients. So
Wow.
it's just ridiculous that we have the option of something so much safer, and
It
we just have to
is.
jump through the insurance hoops to get them there. But
Absolutely.
other than Botox, what other therapies because one thing I hear from patients, if they try a
Mhm.
medicine or two, they'll just say, I just want a surgery to fix it. Just go in there and fix it for me. So there
Yeah.
isn't
Yeah.
exactly just the surgery to fix it, but there are some surgical procedures. What else can we offer patients outside of Botox if they're a little hesitant?
So another option for the overactive bladder patients, we can do what's called sacral neuromodulation. That is a procedure where I always like to describe it as placing a pacemaker for the bladder. And one of the things I really like about that procedure is that there's that trial period where you can actually have just the lead placed and not the full battery, and then you can kind of walk around with it for a week and see if you feel that it helps. That's one option. And then if we're thinking outside of the box, we have some of the at-home pelvic trainers. There's now red light therapy
Mhm.
available. And then we have some other out of the box treatments like CO2 lasers and radio frequency and PRP. So those are all options, but it definitely depends on the patient and their symptoms.
Exactly. And the neurostimulation that you were talking about is can be covered by insurance because that's in the AUA guidelines. But I think the data on some of those alternative therapies like PRP injection and vaginal lasers, I think the initial data is good. It's just not overwhelming and strong yet. So it's not a
Yeah,
part of the guidelines. Those are going to be cash services or outside insured options. But I think we need to keep pushing the envelope on those things because how do we have other options to give women if we don't keep trying?
absolutely. Absolutely. I think that's so important. I'd love to see a lot more studies done, multi-centered, different physicians, as well as prospective studies. I mean, we just need more numbers. We need more data. We
Right.
need more women participating. We need more research dollars. I think that there's a lot of promise for these treatments that are not part of the guidelines at this point in time, but we just have to have the research and development.
Exactly. Because when I talk to patients about bladder Botox or neurostimulation, I can give them real numbers. Here's what I
Yep.
expect. I expect
Mhm.
70% reduction or this much improvement. When I talk to them about some of those alternative therapies, I certainly offer my patients vaginal PRP injections and vaginal laser resurfacing. But I usually will tell them, I can make the vagina a healthier place with these areas, and I might make your incontinence a little better. I'm not
Right.
doing it
Yes.
primarily to make your incontinence better,
Absolutely.
but it might be the bonus that you get from it.
I love that. That's exactly what I said. It could be a positive side effect. And that is what's really important. Patients do have to know. And I think that's what's important about counseling. And sometimes you have patients that have tried multiple different treatment options, physical therapy, medications, surgeries, Botox, and they're at a point where they're like, I'm willing to try anything. And so you have to discuss with them. We may not have all the data that we need, and and this is not going to be covered by your insurance, but it's a possibility that it could have this effect. And as long as I think it's open and discussed and patients know what they're choosing, and it happens to give them positive results, then I think it's great.
Exactly. That's a great way to approach it, especially for people who feel like they've tried everything and they just haven't gotten the results. I do think we have a lot of safety data for those things, for injections and vaginal lasers. I don't think we're going to cause harm, and certainly do no harm is our first credence.
Correct.
So I usually will say to patients, here are the things that I'm pretty sure you're going to get improvement from these
Yep.
alternative therapies. These are the things that might be a bonus, but at least we're not going to worsen anything or cause you any harm.
Absolutely.
Great.
Absolutely. And of course, they always have to be a good candidate for whichever procedure we are discussing. But I think that, a lot of the options are great. The safer neuromodulation is a great option. And I think what I love the most about that is the recent advances, right? With the MRI compatibility of these devices and the battery life. I think that they're a lot more user friendly as well
Exactly.
nowadays.
Yeah. Makes it much easier to almost be a one and done procedure.
Hmm.
The new batteries last 10 years or possibly more. So for many
Yep.
women, that's going to be their only implant that they need.
Right. Right.
Yeah.
I
Well, it
agree.
is always so great to talk with like-minded physicians and really smart
Yeah.
women who share my passion for educating their patients. I just love that. I think the basis of being a physician is educating your patients, sharing the knowledge that we have. So I love hearing that you do that as
Mhm.
well.
I agree. That's really, I feel like if I have a new patient visit with someone, honestly, I feel like the goal is just to talk and go over what's going on, how is it affecting you, what are the options. It really is just an educational session, and then deciding what we want to do.
Exactly. I love when at the end of a new consult, a patient says, this is so fabulous. I didn't realize I was going to get all this information.
Yeah.
And from my point of view, a lot of it to me is very basic information. Like we said at the beginning, what is their basic anatomy? What are all the parts called?
Mhm.
It's something no physician or educator has gone over with them. And they just feel so great leaving that they have a good
Yeah.
grasp of what's happening with them.
Absolutely. Absolutely.
Great.
I
Well,
I enjoy chatting with you all the time.
Well, thank you so much for being a part of it today. We will definitely have you back for more topics. Dr. Sarah St. Louis joining us today to talk about all the things that we wish women knew as a urogynecologist. Thank you so much. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.